Well, good afternoon, everyone, and thank you for attending the Transplant Institute lecture series. My name is Marwan Al-Buzoud, Director of the Transplant Institute, for those who are online. And it's a pleasure today to have our guest, Dr. Timucin from the Mayo Clinic, Rochester, who is going to be talking to us about a very important topic that we're all facing in clinical practice, which is liver transplant immunology. Dr. Tanner's background is very interesting. He's currently now the Roland Dixon Research Scholar at Mayo Clinic and runs a significant research enterprise that is focused on the immunology of the liver and the host and how that impacts the rejection events and the immunology of other organs. And he's also engaged in developing testing mechanisms for that as well, and also some work on genomics in collaboration with other centers. He did his training and got his MD from Ankara, Turkey at Hacettepe University, which is one of the more prominent universities in Turkey, and then came and got a PhD at the University of Pittsburgh in transplant immunology and spent 5 solid years. I don't know how he could have done that, but it is a remarkable achievement where he worked on the dendritic cells and subsequently went to Mayo Clinic where he did the surgical training and transplant surgery training. And he stayed there on staff. He covers all organs. And he's got specific interest in living liver donation as well, and minimally invasive techniques in living donation. And with that, I'm happy to give the podium to Dr. Tanner, and please join me in welcoming him.
Thank you very much, Marvin. Thank you very much for the hospitality and inviting me. It's been an impressive visit so far, and I hope I can entertain you with this talk. So what I'm going to tell you about is what we are doing in liver transplant immunobiology. Again, it's my interest and it's my clinical practice as well. I do liver transplants. I also like to actually call this talk as I go along is to ask what the liver can do for you, because I think we're asking more and more for the liver to do something for us, and it is actually delivering.
Yeah.
So I have nothing to disclose.
At Jacksonville, Mayo Jacksonville.
As most of you know, when you do a transplant, when you transplant a solid organ, this prompts a very strong non-self response from the recipient. This happens through the innate responses initially, the innate response mechanisms through the dendritic cells, through NK cells, through neutrophils. Those are the first cells that infiltrate the organ and start the cascade of reactions, which we call a rejection, and followed by the adaptive responses where we get specific antigen-specific T-cell responses as well as HLA antibody-mediated injury to the graft. This is just a depiction of what happens. This is just showing a liver. When you put in a liver, it comes with a lot of passenger leukocytes, which immediately travel to the draining lymph nodes, see the T cells of the recipient, activate the T cells, which in turn travel back to the organ. And this is what you get in the histology meetings when you go and see a rejection. These are what the T cells do. Similar mechanisms are in effect through the antibodies. Whenever there are donor-specific antibodies, through the mechanisms which I'm going to explain later, injure the liver or the kidney or the heart or whatever you're putting, causing the antibody-mediated rejection. There are several mechanisms the donor-specific antibodies against the donor organ act. Some of these are the antibodies activate the complement system, which through a different chain of reactions cause a membrane attack complex, which directly disrupts the membrane of the cells in the donor. They can activate the antigen-presenting cells through their Fc receptors, as most of these cells have Fc receptors. These are dendritic cells, natural killer cells, macrophages, neutrophils. Antibodies can actually directly injure the endothelial cells, which is now, we are finding out, is one of the main mechanisms of antibody-mediated rejection. And antibodies can also activate the coagulation cascade. This is actually detrimental to the organ as well. So what happens when the donor-specific antibodies bind to the endothelial cells? Because again, the endothelial cells are the first cells that the antibodies would see in a graft. If you think about it, the blood, the first interaction of the blood is to the endothelial cells that are covering the surfaces. They actually activate these endothelial cells, which then can act as chemoattractants for leukocytes and platelets. So there is a start of the inflammation. As a result of this inflammation, there are a bunch of pro-inflammatory cytokines that are secreted within and around the endothelial cells, and then endothelial cells themselves start to proliferate. This all leads to what we call a transplant vasculopathy, all those micro-inflammatory injuries that we see when you go to the histology conference or the kidney, liver. This is what the antibodies do. They injure the endothelial cells, cause almost a reaction akin to ischemia. So this happens in most of the organs that we know. About 10 to 15% of the recipients of kidney, heart, lung transplants will at some point experience antibody-mediated rejection. If you look at just the positive cross-match kidney recipients, you can expect this to happen in about up to 30% of these patients. And the transplant vasculopathy, once you recognize it, is not a good thing if you are that recipient. You know that those people would most likely lose their graft function within the next 5 years. For anybody with a transplant glomerulopathy in the kidney, the 5-year graft survival is only about 20%. So this is better if you recognize it initially and took care of it initially. There's a good literature about antibody-mediated rejection of the kidney, which I'm not going to go over. Same thing about the heart. This is just a representation of what an AMR of the heart looks like. You get a hemorrhagic reaction. This is not what you want to see after you do a heart transplant, obviously. Treatment of antibody-mediated rejection is not easy and it's not cheap. We have tried many things over the years. We targeted memory B cells with the rituximab. We targeted plasma cells with bortezomib, complement system with eculizumab, which used to be the most expensive drug ever. B cells, donor-specific antibodies with IVIG. We target donor-specific antibodies with plasmapheresis when we put these patients through a plasmapheresis and change their plasma. Or we used to do splenectomies before rituximab came about. Each episode of AMR, the treatment of AMR, is thought to cause about $50,000 to $150,000 in the Western world. So it's very expensive. So where does liver come into play? So liver is obviously the largest organ, solid organ that we transplant. Despite that, if you are doing both transplants or many transplants, and again, I do livers and kidneys, you notice that the liver transplant patients require the least amount of immunosuppression, both at the induction. We don't use thymoglobulin like you do. And maintenance immunosuppression is, when we compare to the kidney patients or heart patients, is much less. Despite of all this, we don't see as much chronic immune-mediated injury to the liver. So there's got to be some reason for this. If you look at the liver at a steady state, and I'm not talking about the transplant, you realize that liver is actually managing a lot of antigen really rather well, because everything we eat, all the pathogens that are coming from the gut through the portal vein, go through the liver. Despite this, the liver doesn't get excited. It doesn't just mount an inflammatory response. And also all the antigenic metabolic byproducts that what we ingest goes through the liver. Again, liver has to have this in a very balanced manner, that it can't get inflammation all the time. So it does that with a very effective mechanism to eliminate the microbial pathogens. So it is a very striking balance. If you look at this in detail, you find out that most of the immune cells that we find in our liver are slightly different than the immune cells, their counterparts in anywhere else. The dendritic cells, Kupffer cells, liver sinusoidal endothelial cells all are a part of the liver's innate immune system. Normally, all of these would be activated through their pattern recognition receptors. And normally, when the pattern recognition receptors in a dendritic cell or a Kupffer cell, anywhere else in the body outside the liver, would get ligated through these PRRs, the pattern recognition receptors, would start an inflammatory cascade. They would secrete pro-inflammatory cytokines, there will be acute phase proteins, and this will all attract more leukocytes, and inflammation would start. It is different in the liver. For example, Kupffer cells, which are liver-resident macrophages, and if in your body, 80% of your macrophages are in your liver. Under steady state, if you actually took the Kupffer cells and stimulate them with the LPS, which is a microbial product, unlike their counterparts in other parts of the body, they show a completely different response. They start secreting anti-inflammatory cytokines rather than inflammatory cytokines. They stimulate regulatory T cells, and they induce cytotoxic T cell apoptosis. So completely different than what you would expect a macrophage to do. Liver sinusoidal endothelial cells, similar structure. These are the cells that are just beneath the endothelial cells in the sinusoids. They express low levels of HLA, the human leukocyte antigens. They don't produce the main inflammatory signal, the IL-12. They are very poor stimulators of T cells, and they might actually induce regulatory T cells. This is, of course, thought to be one of the mechanisms through which the hepatitis happens, actually. Liver dendritic cells, in the lab that I got my PhD was a big dendritic cell lab, so some of this data comes from that. The liver dendritic cells are quite different than dendritic cells anywhere else. They suppress T cell proliferation, they induce T cell apoptosis, they induce regulatory T cells, so they act completely different than what other dendritic cells act like. Of course, none of these are foolproof. You do a liver transplant, you can still get a rejection. Some of the explanations to these are the ischemia reperfusion injury probably induces some inflammation, which leads to upregulation of the inflammatory cytokines that are secreted in the liver. For example, Kupffer cells, if you deprive them of oxygen, if they are ischemic, then they change and they start acting like macrophages, and they can recruit neutrophils, dendritic cells, and all the other inflammatory cells. However, having said that, this is still liver, and liver still maintains its sort of tolerogenic, less immunogenic profile, even if you take it out of the body and transplant it to somebody else. So even liver allograft acts differently than a steady-state liver. And this is not new. This was first recognized 30, 40 years ago by the pioneers. Like Kamada was one of them. He recognized in different rat models that you could do a liver transplant. Sir Roy Collin did the same thing in outbred pigs. In some animals, you could do a liver transplant without any immunosuppression, and they would do just fine. And then if you actually took the liver and put it into a pre-sensitized animal, the liver would still survive despite all the antibodies. And if you took the liver and transplanted with a kidney in a rat, transplanted the heart in a rat who would otherwise reject the transplant, would not even reject the heart transplant without any immunosuppression. So this is not a very new phenomenon. It's just like we never followed this up in the human. So we got interested in this and started looking at this when the antibody-mediated rejection in the liver was becoming a fashionable thing. So we asked the question, what happens to the HLA antibodies, or donor-specific antibodies, or DSA for short, after liver transplantation? We simply looked at our own data. We have a protocol to look at donor-specific antibodies in every liver transplant recipient. We take samples pre-op. We also take samples on different times post-op. This is day 7, 4 month, 1 year. Now actually we follow this up with, for longer term data, we look at DSAs every year after liver transplant. And then we just took 94 consecutive cases. This is the only prospective study to date to look at what happens, just interested in this. So we found that in 94 of these patients, the incidence of donor-specific antibodies when they came for a transplant was not that low. And if you think about it, this is not surprising. These are sick patients who require a lot of blood transfusion, platelet transfusion. Anytime they need a intervention, we hit them with something. So it's not surprising that they would be sensitized. They would have a lot of antibodies around. And then we looked at it, just taking a page from the kidney transplant world and the heart transplant world, looked at it with a C4D stain, which is now more common to do, but this is a few years ago. And we stained all of these samples with C4D and asked one of our interested pathologists back then to rate this, who was blinded to the patient's clinical outcome, to give us the results. So, and these are different places where you would look for a C4D stain in the liver. The portal stroma, the portal endothelium, the central vein, the sinusoids. You can look at it. This is the immunohistochemistry. So if you look at the two groups, the donor-specific antibody negative patients, so these are not sensitized by definition, and these are the sensitized patients. Not very surprisingly, we found evidence of C4D staining in some people, and this was regardless of their donor-specific antibody levels. But the only thing that was very common was only in those people with donor-specific antibodies that are positive sensitized patients, we found evidence of diffuse C4D staining. So if you look at a liver, if you saw a lot of C4D staining in everywhere you looked, the chances are there's going to be some circulating donor-specific antibodies at that point. It turned out that the 3 patients with the C4D staining were also the patients who had bad T-cell mediated rejection. So we treated them with our protocol, which is just a solumedrol pulse. And none of them turned out to have any steroid-resistant rejection. And all of those 3 patients did perfectly fine, and nothing else happened. And we followed this for over a year, including the including the donor-specific antibody levels. And we did not do any antibody targeting therapy. So none of these patients received any IVIG, plasmapheresis, none of those things. The labs were not any different between the sensitized and non-sensitized patients. And then looking at the 4-month donor-specific antibody levels, these are the MFIs. It's just what the mean fluorescence intensity of what you get in the flow cytometry for the donor-specific antibodies. Even if people started with very high levels of donor-specific antibodies, just putting the liver in and letting the liver suck up all antibodies without any antibody targeting therapy, you see that by 4 months, most of these people just perfectly are fine clearing their antibodies. There are a few people who increase the levels of donor-specific antibodies with no evidence of rejection or any allograft dysfunction. And then we published this, and we show that, if you look at it in a prospective manner, rather than looking at it with a very biased manner, you can see that most of the time the donor-specific antibodies are cleared by the liver, and the liver doesn't get affected. There are obviously several mechanisms postulated for this effect. People think that the vast hepatic sinusoidal endothelial surface with their HLA-1 expression probably plays a role clearing these antibodies. People have thought that the secreted HLA could be binding to these donor-specific antibodies, subsequently the Kupffer cells uptaking these immune complexes, or it could be just that the liver is the only organ that can take a hit. Unlike a kidney or a heart transplant that undergoes an AMR, antibody-mediated rejection, liver can actually come over this and then start regenerating, and you don't see any evidence of long-term impact on this. Since then, a bunch of studies have been done, and now that actually since last year we have Banff criteria for AMR of the liver for the first time. These are very strict criteria. This was published by the Banff group and Jake Dimitris last year. So to call a liver injury, an antibody-mediated injury, all 4 of these criteria needs to be there. So first of all, there has to be a histopathological pattern of injury consistent with acute AMR. This is mostly in line with the microvasculitis that I was talking to you about at the beginning of this talk. So there has to be a small vessel inflammation. There has to be a positive serum donor-specific antibody at the time of this biopsy. So you have to have evidence of the antibodies. You have to have a diffuse C4D score, just like what I showed you in our study. And there has to be a really reasonable exclusion of other insults, because none of these are very specific. You can have C4D staining in T-cell mediated rejection. You can have C4D staining in recurrent hepatitis C. So all of these criteria need to be met to call a lesion an antibody-mediated rejection of the liver. The active chronic antibody-mediated rejection is not nearly clear. So the Banff group actually did not come up with a very clear definition, unlike the AMR. So there are like 4 criteria for probable chronic mediated antibody-mediated rejection. Again, all of which depends on there has to be an exclusion of any other insult in the liver. So recently, I was lucky enough to be a part of the antibody-mediated rejection of the liver study group sponsored by the AST. So we, about 5 or 6 of us came together. We had discussions, and we came up with these recommendations and just observations. If you look at the literature is not that clear. There's only moderate evidence for what happens to the donor-specific antibodies after transplant. 2 papers looked at donor-specific antibodies. One is prospective, that's our study. The other one was retrospective. Cross-matching data was used a lot in the past, but now we don't think it's specific enough. So overall, the data is not that clear. The association of the antibodies with the T-cell mediated rejection is also very questionable. There's mixed evidence. About 5 papers would argue that the incidence of T-cell mediated rejection would increase if patients are sensitized. And on the other hand, 7 papers would argue that there would be no increase in the TCMR incidence if in the sensitized patients. And there's low evidence that most of the cleared antibodies are class 1. And unlike that, the class 2 is actually stays, and it's harder for the liver to take care of the class 2 antibodies. The graft survival, very similar study, mixed evidence. Some papers would argue that the graft survival is worse in sensitized patients, whereas some papers would say there's absolutely no difference in the graft survival. So overall, we're still not quite there. We don't quite know what the incidence is. What we know is it's very rare. It can happen, but most of the time it doesn't happen, and the liver takes care of the antibodies. So moving on, we also got interested in why is liver less immunogenic overall. So this is not only an antibody-mediated rejection issue. Again, these patients require less immunosuppression than any other organ transplant patients. So what is the mechanism? Why is liver less immunogenic or more tolerogenic in liver transplant patients? So we decided to look at this very systematically, and thinking about how to look at it, we came up with different things. We looked at the clinical results, and we used as the other organ meaning non-liver organ that are transplanted simultaneously with the liver, including the kidney or the heart. So you can look at the clinical results. You can look at this at the molecular and genetic level using the kidney protocol biopsies and see, if you just look at a kidney biopsy, if you can tell that kidney was transplanted with a simultaneous liver or not. And we also look at these in patients' bloods. So you can take a liver patient's blood and compare the immunophenotypes and the functional properties of their T cells to those of a kidney or a heart transplant patient. So there are different ways of doing these. So this is, I'm going to go into the first clinical outcomes. I apologize if you can't see these and these are too small. This is the one study we did when we took the simultaneous liver kidney patients and compared them to kidney patients, just solitary kidney transplant patients alone. We matched them for their immunologic parameters. We also matched them for sex, age, and race. So these are as matched as possible. And we also divided each category into 2, those that are sensitized, coming with positive cross-match, and those that are not sensitized, so straightforward garden variety kidney or liver transplant. So this is just showing you that most of these patients were matched. The differences are mostly in the immunosuppression. As I told you, we don't immunosuppress the liver patients as much as we do the kidney transplant patients. And if you look at the trough tacrolimus levels, you see the differences. We tend to keep our liver transplant patients in a less immunosuppression. So if you look at these, you would argue, because of this, that the kidney patient should have more of a T-cell immunosuppression. If you look at just the kidney transplant survival, you don't see much of a difference in a simultaneous liver kidney transplant patient. They do just fine, as well as a kidney transplant, solitary kidney transplant patient would do. But if you look at the histology and compare the sensitized solitary kidney transplant recipient's histology to a sensitized simultaneous liver kidney transplant patient's kidney, I hope this makes all sense. And we are looking at these protocol biopsies. So we have biopsies from 1 year, 2 years, and 5 years. You see that the cumulative incidence of antibody-mediated rejection in a kidney alone is much higher than if that kidney were transplanted with a liver. So the liver seems to protect the kidney from an antibody-mediated injury. This is also evident in the chronic transplant glomerulopathy. This is, again, the prototypical histologic finding you would see in an antibody-mediated rejection. Overall, the cumulative incidence is remarkably different. You almost never see this in a kidney that has been transplanted simultaneously with a liver. despite a lower immunosuppression. The overall, if you look at the causes of death, censored kidney allograft loss, some, not many, but some of the kidneys that have been transplanted alone have been lost to immune-mediated injury, whereas in the simultaneous liver kidney patients, we hardly ever lose one of those kidneys to immune-mediated injury. If you look at the eGFR and see what happens if this actually translates into the function, and to do this, we took the 4-month eGFR as baseline, because in a liver kidney patient, there's a bunch of stuff that goes on between the time of the transplant to 4 months. So we took 4 months and compared these patients' GFR to their GFR at 5 years. So this is about a 5-year follow-up. Overall, if you just receive a kidney transplant, and if you're not sensitized, you do okay, but there's a chance that you might lose some of your graft function within the first 5 years. This is compared to if you had a liver and a kidney transplant, the chances are you're not going to lose much of your eGFR within the first 5 years. I bet this will be even longer. If you're a sensitized patient, so you're a higher risk of antibody-mediated rejection, and if you get a kidney transplant alone, the chances are your GFR will go down. This is almost guaranteed within the first 5 years. Whereas if you had a liver and a kidney transplant, you're going to keep that GFR. That's not going to be much different. So even functionally, it looks like the liver helps protect your GFR if you have a simultaneous liver-kidney transplant. To see what happened to the donor-specific antibodies in these patients, we also, just like I showed you in the previous study, we looked at the donor-specific antibodies up to 5 years, trying to see what happens. As we saw in our previous prospective study, most of the patients, liver patients, would actually clear their antibodies, regardless of how high their MFIs are. So these are people who are transplanted with like a MFI of 18,000, MFI of 13,000, without any antibody targeting therapy. Just with the liver transplant, these guys actually clear their donor-specific antibodies. You don't see any evidence of donor-specific antibodies up to 5 years. There is, however, a handful of people who had a simultaneous liver-kidney transplant and did not clear their antibodies. And when we looked at these in detail, we saw that there was almost always something going on with the liver. So non-compliant, not taking their medications, or this patient had a recurrent hep C with a fibrosis, recurrent hep C with a fibrosis. This patient had a de novo NASH with stage 4 fibrosis. So it appears that if you have a liver that is working, it'll really take care of your antibodies. But if you don't take care of your liver, then it won't take care of you. Same thing here, the same story. These are de novo donor-specific antibodies. If you look at the people who did not come in a sensitized manner, so they did not have any donor-specific antibodies, but through our prospective DSA checking, we found antibodies years later. You see that most of these people have some sort of a risk factor, and these are just from our database. So these are placed by our coordinators who have no knowledge of the donor-specific antibodies. So these are completely separate, blinded. So this patient was non-compliant, started to get a donor-specific antibody at 1 year, and then persisted at 5 years, non-compliant. Again, this patient has BK viremia, so there was some reason for an antigen exposure. If you look at the non-sensitized patients, these guys should be completely low risk immunologically, shouldn't really have a lot of rejection. Even here, you see a lot of differences. Based on the protocol biopsies, if you look at these, if you receive a solitary kidney, about 30% risk of you having a T-cell mediated rejection within the first 5 years, which goes with the literature and any other group. However, if you have a simultaneous liver-kidney transplant, your chances of having a T-cell mediated rejection is only about 7% based on protocol biopsy. So this is, again, different. Even the inflammation that doesn't meet the Banff criteria, so subclinical inflammation, is different. Overall, the 5-year difference, you're more likely to have a subclinical inflammation if you are a recipient of solitary kidney transplant. Again, the graft and the patient survivals are not any different if you do a simultaneous liver kidney versus a solitary kidney transplant. And if you do a multivariable model and put all these trying to control for everything that you have, including cold ischemia time, the ECD status of the donor, all those things, what appears is that having a simultaneous liver transplant is the best thing for a kidney to have, because it decreases your risk of having an antibody-mediated rejection in the kidney tremendously. It decreases your risk of having a T-cell-mediated rejection in the kidney tremendously. And overall, your functional decline will be much less if you had a simultaneous liver transplant. And we published this as well, trying to see if this was actually a kidney-related phenomena, because you can never be sure. We looked at our relatively large heart and liver, simultaneous heart and liver transplant population, and we compared these to solitary heart transplant patients. Again, this is just the demographic data showing that these patients, the two groups that are either simultaneous heart-liver or isolated heart-liver patients, they are not much different. Even immunologically, they are not much different. Some of these patients are highly sensitized, and we do a lot of protocol biopsies in the kidney, but if you want to really see who biopsies their organs much more than us, those are the heart guys, because they biopsy the heck out of the heart. So we looked at about 5,000 heart biopsies to do this study, and I'm going to show you. So if you look at the incidence of AMR, because of the size, it wasn't much different. There was 14–15% of antibody-mediated rejection if you had an isolated heart transplant, and only about 4.5% if you had a simultaneous liver and heart transplant. And one of the dreaded complications after a heart transplant is cardiac allograft vasculopathy, which is thought to be mainly driven by antibody-mediated injury. This was really different. About 2/3 of the people who had a heart transplant alone would develop cardiac allograft vasculopathy. There's no treatment for this. You can't really turn the heart around, whereas this incidence was lower if you had a simultaneous liver transplant, and the time for development of cardiac allograft vasculopathy was about twice as long in the simultaneous heart and liver transplant patients. The overall patient survival was not any different, so these patients tend to do okay, as sick as they are. So strikingly, although we looked at this from a perspective of the antibody-mediated rejection, we found similar results in the heart transplant patients as we did in the kidney transplant patients, in that the T-cell mediated rejection incidence is really, really different. If you do enough heart biopsies, you would find that almost 85% of the heart biopsies would have some evidence of T-cell rejection. Granted, most of these are ISHLT grade 1, so these are the ones that the cardiologist or transplant cardiologist would elect not to treat most of the time. But quite a few of these had grade 2, grade 3 rejections that needed to be treated with intervention. So T-cell mediated rejection in the heart, again, is not good. Whereas we did not have any grade 2 or grade 3 rejection in the hearts of a simultaneous heart-liver transplant patients. Again, starkly different. The time of rejections are different. The time to first rejection is different. Just like it did to kidney, the liver seems to protect the heart if it's transplanted simultaneously. These are just graphic representations of freedom from T-cell mediated rejection. You see the difference. A lot of T-cell mediated rejection within the first 2 years of the isolated heart transplant recipients, and overall freedom from rejection. This is combined antibody-mediated and cell-mediated rejection. So liver tends to protect the kidney from rejection. We used similar approach. We did multivariable models trying to control for every factor that we can. And just like we saw in the kidney, if you have a simultaneous liver transplant with your heart transplant, the chances are you're not going to have as much T-cell mediated rejection, and you're not going to have as much antibody-mediated rejection. And overall, your cardiac allograft vasculopathy incidence will be much lower. And this is with comparable groups with similar immunologic risk groups. and we published this as well. So trying to go deeper and try to understand the mechanisms, we then went into the molecular and genetic expressions, and again, we went back to the simultaneous liver-kidney patients and decided to look at the kidney allograft biopsies. To do so, we went back to our original 4 groups. These are negative cross-match solitary kidney transplant patients, positive cross-match kidney transplant patients. These are negative cross-match simultaneous liver-kidney patients, and positive cross-match simultaneous liver-kidney patients, just in hopes of trying to get as granular as possible. And these are the comparative, the demographics. Overall, again, the patients who are transplanted just with a kidney tend to be on a higher dose of Prograf, and we tend to run their Prografs a little higher. So what we did is we took their kidney biopsies, and we only took the kidney biopsies at 1 year, just to make the playing field very level. And we only took the 1-year biopsies with no evidence of rejection to make it very fair. So if any of these biopsies, if I took these biopsies and gave it to a kidney pathologist, that kidney pathologist will definitely tell me that there's no rejection, Banff criteria rejection going on. So these are completely stable kidneys, 1-year biopsies, just came back to Mayo to have their 1-year biopsies done, and they went home. So kidneys are doing fine, eGFRs are fine. So the question is, if you look at the kidney, can you find evidence of a simultaneous liver transplant in the form of something that would explain the immunoprotection? And these are, sorry if you're not familiar with these are all the Banff criteria for different lesions to, in a kidney allograft. So there is no difference in any of these things. This is a busy slide. I'm just showing it to show that we did 4-way analyses, given that we had 4 different groups. If you just compare a positive cross-match kidney transplant to a negative cross-match kidney transplant, so forget the liver for a while, so these are regular kidney transplant patients, sensitized or not, as we and others have shown previously, in a perfectly functioning kidney, you can see evidence of increased expression of all these transcripts that are related to inflammation. So there's all these pathogenesis-based transcript sets, inflammation, cytotoxic T cell pathways, all these nasty things that we don't want to find in a kidney, you can see in a positive cross-match in a sensitized patient, which makes sense because antibodies are never good. Again, as I showed you before, if you have antibodies, you're not going to do well. If you do the same analysis in a simultaneous liver-kidney transplanted patient, so you're comparing the positive cross-match simultaneous liver-kidney patient to a negative cross-match simultaneous liver-kidney transplant, you hardly see any of those transcripts that are upregulated. So despite that the patients are similarly sensitized, just by putting a liver in the kidney, you can see evidence of absence of injury. In contrast, there are a bunch of these transcript sets that we found were upregulated in the kidneys of simultaneous liver-kidney patients, and these are all the pathways that are associated with metabolism and cellular regeneration, that kind of stuff. So we had to look, as most gene array data, we had to look up all these, and I had to learn a lot of stuff. But all these things, all these inflammation markers that we expected to find, we didn't find. And in turn, we found all these new genes that were upregulated in a simultaneous liver-kidney patients, kidney patients. The difference was so stark that we came up with this Venn diagram. Of all these 5,000 genes, there's only about 33 that are going in the same direction in a similar patient, with the only exception that one patient had a liver and the other patient did not have a liver. So a lot of things are happening at the genetic level that we don't see. We just see the end result of it with a better GFR and better graft survival. And I put this because this shows it very nicely. This is showing the differences between a positive cross-match kidney transplant patient to a negative cross-match kidney transplant patient. All these red dots, which signify, to the right of 0, signifies a statistically significant fold change. So these are transcripts that are upregulated. are related to inflammation. You see a vast majority of them are related to inflammation. Whereas if there is a simultaneous liver transplant associated with it, about 20 centimeters up north, you see that the inflammation genes, the same genes, are actually, most of them are downregulated. You don't see as much, whereas all these metabolism, tissue integrity, cellular regeneration pathways, these are all upregulated. So somehow liver, just being there, upregulates these genes, which are very helpful to the kidney. If you compare the sensitized solitary kidney patient to a sensitized simultaneous liver kidney patient, you also see a lot of differences. All these genes that are related to endothelial cell associated transcripts, these are going back to the endothelial cell injury and activation, which is the hallmark of antibody-mediated rejection, these are all much higher in a kidney transplant compared to a simultaneous kidney transplant. And so are these inflammation-associated transcripts. So there's a bunch of bad stuff going on in a sensitized kidney transplant patient, even at 1 year, when there's no evidence of kidney allograft dysfunction. And none of these are ongoing if there is a liver associated with a kidney transplant. And again, we published this recently as well. So this is fine, but how is this happening? So this is our next level. Now we are looking into the peripheral blood mechanisms, because if you see this in the kidney, you should probably see it in the blood. And to do those, we do cellular assays. These are just in vitro studies, because it's very hard to replicate the initial studies that were done in rats that I showed you in humans, because we can't do that. So what we do is we take blood from our recipients, either kidney recipients or liver recipients, with or without a kidney transplant. We look at them phenotypically. We stimulate them with their donor antigens in vitro and see if we can find any differences. And this is what it is. So we do these mixed leukocyte reactions, the interferon gamma ELISpots, which have been shown to correlate pretty well with the kidney allograft function and the risk of rejection. So we do all these things. So just phenotypically, we got the help from our Mayo Clinic Human Cellular Therapy Lab, which does a lot of immunophenotyping for cancer patients, pre or post chemotherapy. So they're very experienced in this. They have this 10-color flow cytometric protocol that can go up to identify 40 different types of cells in peripheral blood. These are non-overlapping cells, so they're set up so you can actually see an activated T cell, you can see, NK cell, all those kind of things. And just to see, we just pulled about 35 kidney transplant patients' blood at 1 year, and we pulled about 32, 33 liver transplant patients' blood at the same time, 1 year, and just looked at it. So there are some differences. If you look at the overall percentage of the CD4 T cells, overall, the liver patients tend to have more or higher frequency of C4D T cells. And in contrast, they have a lower frequency of CD8 T cells. And if you just tabulate it as a CD4 to CD8 ratio, this is more like a normal, healthy individual, because you expect the CD4 to CD8 ratio to be somewhere between 1 and 2 in a healthy individual. Whereas in a kidney transplant patient, it's much lower. So these patients tend to have more CD8 T cells. The activation markers, which are here, CD154, which is a T cell CD4 ligand that the activated T cells express, or PD1, this is again an activation signal. If you look at those in the C4D compartment, you see that the kidney patients tend to have more activated T cells compared to liver patients. And in the CD8, or the same thing here, the CD4 compartment, these patients, the kidney patients, tend to have a higher frequency of activated PD1 positive T cells compared to the liver patients. The differences in the CD8 T cells were not much different. I should tell you that these patients were selected so that they did not have any rejection in the previous year. So these are completely steady state, I should say, transplant patients. And we also selected for patients who did not have any evidence of bacterial, fungal, or viral infection within the preceding 6 months. So low immunological risk, But even at that stage, you see that immunophenotypically, there are differences between a liver and a kidney transplant patient. One argument is that the liver patients might have more Treg cells, regulatory T cells. Several groups have shown that in their tolerant patients. We did not see any evidence of that. In fact, there were the frequency of the Treg cells was a little higher in the kidney transplant patients, but not statistically significant. And if you look at the memory T cell compartments, there are again differences. So when we talk about memory T cells, we usually talk about either effector memory cells, which are thought to be the main instigators of rejection, and central memory T cells. Central memory T cells are those that express the memory phenotype, but are mostly in the lymphoid organs. If you look at the effective memory T cells in the CD4 compartment, just like the activated T cells, the kidney patients tend to have more of a memory T cells, and the central memory T cells are not much different. So there is evidence that there are more effector T cells, effector memory T cells in the kidney population compared to the liver population. That's why they're rejecting more often. And if you stimulate them in vitro, this is what you get. So this is our in vitro assays. The left panel here is our mixed leukocyte reaction. We take our recipients' T cells and stimulate them with either their donor cells, which have been obtained at the time of procurement and cryopreserved the same manner as the recipient cells, or with third-party cells. These are just cells from healthy individuals. If you take a kidney transplant patient's T cells and stimulate with their donors, you get a healthy response. This is a pretty good response. It's heterogeneous, but it's pretty good. And if you take the same cells and stimulate with a third party, you see that the response goes higher, which is not very surprising. But if you take a liver transplant recipient's T cells and stimulate against their donor cells, you see that this response is very homogeneous and much dampened compared to the kidney transplant T cells. So these cells, for some reason, are really hyper-responsive to their donors. And I say that because when you stimulate that with a third party, this response goes sky high. This is just, they are not just lazy cells laying around. They do like to get activated to a third party stimulation. They just are very hyper-responsive to their donors. So whatever his liver is doing, it is very antigen specific. And there, if you see these triangles in different, one is filled, one is not. The not filled ones are those that have been the T cells of simultaneous liver kidney transplant patients. Just to show you that those patients' T cells behave just like the T cells of a liver transplant patient. So just putting a liver in, you are somehow rendering your T cells hyper-responsive to alloantigen specific, in an alloantigen specific manner. We repeated these with an interferon gamma ELISpot assay. Similar setup. The responder here is a kidney recipient T cells. They respond very nicely to their donors. Per 300,000 T cells, you get about 400 spots on average. Again, very heterogeneous response. But if you do the same experiment in the same setting with a liver transplant recipient's T cells, you see that they don't really produce as much interferon gamma spots, or the frequency of interferon gamma spots is just much lower. I should remind you that the proliferation assay is thought to be a reflection of both a effector and the memory T cell responses, and the interferon gamma spot assay is a reflection of just the memory T cells. So this is just functional assay for a memory T cell. Again, this difference is very significant and very obvious. If you stimulate the kidney recipient cells with third party, it's slightly less, which is what you expect because these cells have never developed any memory to the third party. This is the first time they're seeing it. And these cells, again, not much different because you wouldn't expect these cells to respond to the third party anyway. So in a very alloantigen specific manner, it appears that the T cells of the liver recipients are much hyper-responsive to their donors. Finally, to look at this in more detail in the proliferation assays, we switched to this what's called a CFSC dilution assay. This is just a flow-based assay when you put the donor cells and the recipient cells, and then you label these recipient cells with CFSC and see how, as they divide, the amount of CFSC is divided into two, so the amount gets less and less, and you can actually quantify that with a flow cytometry. So the groups are here. Let's start from here. If you get a kidney donor and a kidney recipient in the same well, and then you label the kidney recipient cells, you see a healthy population that upregulates the CD154, which is the T cell marker, and then they proliferate quite a bit. Whereas you do the same experiment in a liver donor and liver recipient combo, you don't see nearly as much proliferation of these cells. They upregulate their CD154 a little bit, and then they just don't proliferate as much. Very antigen specific, just as I showed you in the MLRs. If you do this with a third party, these cells go crazy. They just start reacting to it. So they are not just lazy. They are not just sitting there. It's very antigen specific. The kidney recipient cells do the same thing. And this is also true for the CD8 compartment. The kidney recipient cells, the CD8 T cells from the kidney recipients, like to react to their donors, unlike their liver recipient cells. So overall, in summary, we know that liver is, as we were discussing with the fellows this morning, liver is probably one of the biggest immunologic organs. It carries 80% of your macrophages, and we transplant this organ, and we forget about it, but it probably continues to serve as a very immunologically active organ. And we see that there is reduced incidence of alloimmune injury in simultaneously transplanted organs, just using these organs as surrogates. If you look at the gene level, you can see a difference. So if you give us 2 kidney biopsies and we do gene arrays, we can probably tell you which kidney came from a patient who got a liver transplant and a patient who did not get a liver transplant. So even that makes a difference. Everybody's feared endothelial cell activation and injury is much less common in positive cross-match, so antibody-ridden simultaneous liver kidney transplant patients. And again, at the molecular genetic level, those kidneys that are transplanted in a very highly sensitized patient look just like a non-sensitized, very regular, easiest kidney transplant alone. And phenotypically and functionally, I think we are at the point that we can show that the liver transplant patients have a much reduced alloimmune reactivity. And this appears to be very antigen specific. So that's where we are. We are continuing with our studies to find out what causes this, because these are yet still observational and we don't have a complete mechanism. We're just identifying what we can see. But there has to be some mechanism through which this liver does this, and with the hopes of finding. So with that, I think I'll stop and entertain any questions you might have.
Questions? Maybe I can start with the first question. First, thank you for a wonderful talk. With this, now you feel more optimistic that when you do liver transplant, simultaneous liver kidney, that the immunologic events are going to be reduced.
Yes.
So in your program, doing 130 some or so livers in a year, how many times in a year do you have to treat a patient for what you believe is an antibody-mediated rejection?
In a combined liver?
In general, yeah.
So we treated 1 person in the last 5 years. So the incidence in our hands is much lower.
Okay.
I can't tell you why we see it much lower than in some other centers. We do have probably a more homogeneous population.
Okay.
We're in the middle of cornfields in Minnesota.
Yeah.
So it's a little different. I acknowledge that every time, but we do, follow our patients maybe a little more vigorously, and we do make sure they take their meds. Compared to, and you guys are the same. I'm talking about some other programs that find this much higher incidence of antibody-mediated rejection.
Yeah.
And it appears that most of the programs that claim that they have a higher incidence of AMR tend to have a more of an mTOR-based immunosuppression rather than a prograph-based immunosuppression.
Yeah.
That's my suspicion. I don't have
Sure.
any evidence for that.
The other question corollary to that, have you looked in addition to the biopsies to using microRNAs or the TrueGraph from Transplant Genomics as a marker for subclinical rejection instead of just the biopsies?
No, we haven't done that.
Yeah,
We
okay.
have some ongoing studies similar to those, but we haven't done those yet.
Okay, all right. Open the floor. Any questions? All right, Dilip, you're preparing?
Well, I was talking to basic scientists once, and I mentioned this concept of the liver protecting the kidney. So this guy's a basic scientist, so his observation was, well, why don't you just throw in a little bit of liver every time you do a kidney transplant? So
It's amazing how many times I hear that from people who don't do liver transplants. It's just amazing.
you're almost tempted to borrow a little bit of the left lobe.
Right.
Yeah, slip it in the groin, actually.
People ask me, seriously, people ask me that question all the time as if this is just a, non-issue.
But it does get to the issue of trying to figure out how we can reproduce this without actually doing it.
Absolutely, yes. And we're not there yet. We're just,
Starting to sort that out.
and none of this is new. Again, Kamada did this, Sir Roy did this like 40 years ago. We just never followed up on that.
Yeah. So I guess the question would be in programs like ours where we have a great deal of African American population or ethnically diverse population,
Right.
in addition to other elements that are sensitizing, non-compliance notwithstanding. Should there be an effort to study that perhaps in a
Absolutely,
different
yeah.
context like
Yep,
this?
absolutely, yeah.
Duplicating some of that?
Absolutely. I think we'll have to, right.
Okay.
I acknowledge our population is less heterogeneous than yours, no doubt about it.
Yeah. Okay. Any other questions? Well, thank you. Oh, there's Sunji.
Thank you for a great lecture. So, a question about the immunosuppression protocol. If you do a positive cross-match kidney transplant alone and then SLK, do you change any immunosuppression reaction or maintenance?
So we have protocols. So the protocol for a positive cross-match kidney transplant alone will be a thymo induction, followed by triple immunosuppression. And for a liver kidney, we would just do basiliximab induction.
You don't use the basiliximab for the just liver transplant alone because no positive.
No. So our practice is we just do 500 of solid medrol. That's our only induction, if you call it induction.
No, you never see like AMR positive cross-match SLK.
So no. There, in this cohort, we didn't. Again, as I was talking to the fellows before, that could happen. We have seen it once since then, and initially, the first week or so, the liver is not as good a protector because liver itself is trying to go through the ischemia reperfusion injury. So I postulate that if that happens, you would have to treat the AMR of the kidney, no doubt about it. But if you give it enough time, you don't get these long-term effects of antibody on the kidney. You don't get the transplant glomerulopathy.
Interesting. All right. Well, thank you, Dr. Taylor, for a wonderful
Thank you.
presentation.
Thanks.